middle of the conference, and we're super excited to hear everyone speak. So right now, what I'm going to do is I'm going to pass it off to Emma, who will be leading this portion of the session. Thank you so much, Emma.
Hi everyone, I'm Emma. And in the interest of time, let's get right into the super exciting section. This is personally my favorite part of the conference every single year. And we're so excited to talk about the incredible work that has happened in the last year, especially relating to feminist health and health resilience and gender health and equity. Today, we're hearing from five incredible speakers who will share their research and their projects and knowledge relating to the various aspects of gender health equity. Just to give everyone a kind of an idea of our setup, every speaker is going to be giving about a 7-minute presentation, and we'll have about 5 minutes for Q&A. Feel free to leave your comments in the chat while the speakers are speaking, and I can pass them along to them during the Q&A session immediately after. So without further ado, let's welcome our first speaker, Dia Chopra Laham.
Thank you so much, Emma. It's great to meet everyone. And just confirming you can see and hear me. Maybe, Emma, you could confirm for me.
Yes.
Okay.
We cannot see you, but we can hear you.
Oh, interesting. Okay, let me just, there we
Oh,
go.
now we can see you.
Yeah. Okay, perfect. All right. And I'll just go ahead and share my screen and let me know. You know what? I actually have to update my settings. Sorry about that. Just give me one moment here.
No worries. I think we all have experienced this on Zoom. This is the perfect time to update settings.
Okay, I'm just going to rejoin. I'll be back in 1 minute.
Perfect.
Emma, if you want, we can get started with the next speaker and then have Dia go second.
Yes, I was just thinking the same thing. So we're going to welcome our second speaker, Chris Wong.
Hello. Let's see if I can get my screen to share. Okay, it is shared. Oh, hold on. Give me a second. Sharing. Okay, it's shared. Hello. My name is Chris White. I use he, him pronouns. I'm a first year at the University of Toronto, hoping to study statistics and public health. I'm presenting research that was conducted when I was in grade 12 for the British Columbian capstone project, which is a graduation project that every grade 12 is required to complete for their career education program. So my presentation talks about like the children year for 2S LGBTQIA plus sex ed. We're mostly going to talk about the results from the BC Sexual Health Education Survey that I conducted in grade 12. And if we have time, I'll share ways to make sexual health education more 2S LGBTQIA plus inclusive. Yes. So before we begin, I just want to preface with a note on the word queer. I know that I recognize that many people who may or may not be in this meeting have faced prejudice or have heard the word queer being used as a slur. I just wanted to recognize the historical significance of the term and state that queer will be used in this presentation as both an identity for people who do not identify as cis heterosexual and also as a political term that refers to sexual health practices specifically that exist outside of cis heterosexuality. So method overview, I do have to check this out in high school, so this is not maybe a good methodology. But basically, I conducted a province-wide survey that gathered responses from 51 participants ages 14 to 20. More specifically, it was looking at grade 8s to people who graduated high school 2 years ago, so in 2022. These responses were collected in a Google Forms, and participants were warned that Google Forms is not necessarily the secure place to store information. And the way that this survey was publicized and spread out was that I posted it on my Instagram story and on other social media platforms. And I also made posters that I put up around my high school, around my friends' high schools, and I gave out posters to put out around community centers. So that's where the responses came from. These are demographics. 53% of participants identified as queer, in this case meaning not heterosexual. 29 participants identified as genderqueer, in this case meaning not cisgender, and 25% of participants identified as on the A spectrum. And this is just showing what grades these participants fell into, as in like year level. So as you can see, the vast majority of the participants were like, shall we say, like 16 and up, but we did have 7 participants that are younger. So delving into the research, 88% of participants said that they were taught sexual health education in school, yet 88% of that group said that they have looked up sexual health information online, suggesting that their school had failed to provide that information. This was very much inspired by secondary teacher Zhurling Chong's research that delved into both school-based sexual health education and online sexual health education, and that we need to compare the disparity between the two to see what children are missing from their sexual health in school. The pink boxes here are what I would traditionally call not related to 2S LGBTQIA plus topics, although one could argue that kinks, masturbation, pleasure, etc., like those do fall into what we would consider queer sex ed. And the purple, which is sexuality, queer sexual health. This box doesn't have a label, but it's gender identities and other, I suppose. These are what we would consider more traditionally as 2S LGBTQIA plus topics in sexual health. When asked what subjects they would like to see taught in sexual health education, 57% of participants suggested teaching 2S LGBTQIA plus topics. And this pie graph shows the identities that these participants fell to. And so we had 1 preferring not to disclose, 8 genderqueer people, 6 queer people, and I believe that should say 2 cis heterosexual people. Yes. And this is relevant for 2 reasons. I think it's worth pointing out that we had 2 cis heterosexual participants suggesting teaching 2S LGBTQI plus topics, which is a topic that many educators find to only be relevant to a minority of students, which this is not the case. We find that cis heterosexual students do want to learn about 2S LGBTQI plus topics in sexual health education, and also that this was asked what subjects they would like to be taught in sexual health education in general. I'm certain that if we were to specifically ask students, would you like to see 2S LGBTQI plus topics taught in school, we would have a higher percentage of participants saying yes. But yeah. Oh, oopsies. So this is just a breakdown of what exactly students suggested teaching in sexual health education. So we have trans identities, sexual identities, trans-specific sexual health, queer-specific sexual health, and other. And I have the information on what these categories entail on the side. But yes, as you can see, we had more people ask about queer-specific sexual health than sexual identities, but we had more trans identities and trans-specific sexual health, presumably because less trans people answered the survey than queer people, cisgender queer people. These are some responses that people like gave for that question. My favorite is just acknowledge that queer people exist. Yeah, you can read them. Oh, sure, what's going on? And I guess the summary of my topic is that like the adults having this conversation want to convince us that children should not be learning about 2S LGBTQIA plus sex. We have the parents' rights movement. We have the recent election. We have Pierre Poilievre saying that he would do his best to like ban trans people in gendered washrooms. We have like legislation being passed in those fields. But we find that children learn 2S LGBTQIA plus sex ed anyway, and they want to see it in class. And so I think this speaks to the fact that when given the opportunity, teenagers do care about their sex ed, and what they care about is that they want a more equitable and inclusive sexual health education. And these are just some ways that incorporate these topics into sex ed, use inclusive language, include 2S LGBTQIA plus people in lessons, and provide 2S LGBTQIA plus specific. Yeah, that's my presentation. Thank you for listening. Sorry, I have to go really fast, but yes.
No, you were right on time. Thank you so much. This was really, really interesting. I also just want to give a quick shout out to amazing graphics on your slides.
Oh, thank you.
I think that's something that some of us in the sciences can sometimes struggle with, at least I can, at least personally. Um, but I actually have a quick question. I know, and maybe kind of going toward that last slide that you had to breeze through a little bit in the interest of time. But just for context, so I grew up in Florida, which obviously is one of these states, at least in the United States, that is really targeting the parents' rights movement and things like that in the like in elementary school and K through 12 classes. So could you kind of speak to that last slide that you went through of how can we advocate and do more to incorporate more diverse topics into sex ed?
I think the way to do it is to ask students what they would like to see. I think the way to do it is by asking, because like there was more to this slide, but it's like what students were looking for that were not to us LGBTQIA plus sex ed. Students were looking for destigmatizing sexual health education, providing more training for the teachers who teach sexual health education, which are typically gym teachers in BC. Um, Providing more resources to accessing safer sex tools such as like abortion clinics, testing clinics, etc. And so like I think part of like making it more inclusive, I suppose, is by giving that power back to students because students are the most are obviously the most affected by sexual health education changes, and they are typically the least represented in the discussion that we have around sex ed. I think in general, I think like the parents' rights movement, something to note about that is that while they are very loud and while they have a lot of impact on legislation in particular, they are not the majority. And so if we can have the silent majority like care about these topics, like I find that's the most important thing because again, like the parents' rights movement speaks to a minority of people. The majority of people do want, let's say, LGBTQIA plus education in schools. And so to get those people empowered and on the streets, et cetera, is what I think will be the most helpful.
Thank you. That's such a thoughtful response, and I think that's something we all can think and advocate more about is really centering the perspective of the students who are actually receiving this education. Does anyone else have any questions? We have time for one more. Let's see. Yes, Daria.
Yeah, I actually had a quick question. I know that obviously you did this as a project last year, and I was just kind of wondering if there's a future for this work and if it's something that you're kind of continuing to work on or how you're kind of thinking about incorporating these ideas into any of your future work, if you are.
Yeah, so this was for like career education in my high school program. And like I feel like I was the most affected this program was the most effective for me because it really showed me what I want to do with my work in the future. Like I'm very interested in like teenage attitudes towards sexual health and how like teenage attitudes towards queer sexual health in particular and how people access this information. It doesn't really get talked about in this presentation, but I did a lot of research into like where teenagers get like sexual health information online and how that has impacted their sexual health education. And so that's probably what I want to do in the future. We'll see. I'm also very tiny, and still I have a lot of time to figure it out. But yeah, I'm really passionate about this, and I would love to continue.
That's amazing. Well, we here at Medical History all know that, this is always a welcome place to come and share any of that work that you do as well. And we thank you for this work.
Of
Amazing. So
course.
thank you so much, Chris. And let's see. Dia, are you ready to go?
Already, yes. Great.
Okay.
A tough act to follow with Chris. That was great. All right, I'll go ahead and share my screen and let me know if you guys can see this.
Looks great.
Okay, perfect. Yeah, so just a quick intro. My name's Dia Chopra. I'm a strategic consultant by day, and like many of you, a patient advocate on my weekends and in my free time. I've just started tinkering with a content education platform called Rewired Health. And I'm here today really to share my story. I lived with a chronic condition after a bike accident for almost 2 years. A lot of you might be able to relate to, I went in and out of the medical system, different therapist offices, and the impacts and the lessons I've learned are so necessary for predominantly women who experience these conditions. And I would love to get my word out there today. So, just a little bit of background. In the winter of 2020, I was super active. I was a high functioning woman. I was skateboarding, surfing, rock climbing, working at an emerging startup in the tech industry, speaking at conferences, a bit of a type A perfectionist overthinker, which happens to be the type of person who can be susceptible to chronic conditions sometimes. And without painting a broad picture, that's exactly what happened to me. In September of 2020, in the peak of COVID just hitting, I took a short weekend getaway. So I just went out to Grand Bend. I wanted to, swim in the lake, let my hair down, relax, figure out where I wanted to go with my life next. And on that trip, I actually ended up in a bike accident. I figured, I had a few bumps and bruises. I ended up with a minor concussion. Maybe I'd recover in a few days. 10 days passed, 20 days passed, 3 months, 8 months, 12 months, a year and a half, and I was virtually couch ridden. I ended up with persistent concussion symptoms for almost 2 years. The impact on my life was I lost my job because I couldn't function. I stopped driving, looking at screens, working, reading, exercising beyond a 20-minute walk, which is what I had been told by a number of therapists to keep that at a maximum. I stopped grocery shopping, going any place busy because it was overstimulating. I spent probably over 40K in expenses on therapies, supplements, healthcare, practitioner services, and just suffered from impaired relationships. My family ended up becoming my caregivers. This is just a snapshot of some of the symptoms I had experienced. This was not just a few days post injury, but it lasted. And that's the key here. Most folks do recover after a concussion within a reasonable period of time. There is a smaller segment of society, a lot of them happen to be women, who end up living with symptoms for years. I don't just mean 2 or 3 years, but sometimes 10, 15, 20 years. They are invisible conditions, they are suffering silently, and there is very little help for them out there. But there is a way out. These are just some of the therapies I had been recommended by doctors, and I, as a type A, made sure I pursued each and every one. The thing is, I was told if I don't pursue a combination of these therapies, I won't get better. And that right there is what started the vicious cycle for me. See, in my brain, I thought there was actually something broken, something wrong. What I would later learn is I had actually completely physically recovered, both in brain and body, probably 10 to 15 days after the accident. All of the symptoms I lived with after that were fight or flight response. This is just a snapshot of some of the advice I had been given. And you can tell off the bat for someone who's already a little bit on the higher end of the anxiety spectrum, this was scary for me. Why couldn't I look at screens? Why did I have to time my exercise? Why couldn't I let my heart rate exceed a certain BPM? It just didn't make sense. Now, I want to asterisk this because there is really important conversations happening out there around safe return to play. There are football players who return to the field too soon. There are people with more major concussions who don't get the right help. I am not speaking about this audience. I am speaking about a segment of society who ends up with this condition for absolutely no reason other than their own fear and belief system, what they've been told by practitioners that's keeping that vicious cycle alive. January. This is about a year and 4 months after the accident. I have been at this point sitting in a bathrobe in my parents' house in a dimly lit room, listening to a podcast when I could tolerate it, making myself one meal a day, not being able to work, still not looking at screens, driving, going to the grocery store, etc. And I end up in a psychologist's office who teaches me this. It's called the fear symptom cycle. And the idea here is that the more we think something is creating an issue for us, the more it actually will. Our belief system is paramount. I'm happy to report, spoiler alert, that today I am fully recovered. I learned the tools from my psychologist and what's called mind body work or neuroplastic pain, neuroplastic symptoms. That there is actually a way to overcome these kinds of conditions. And we do it through the response in our brain, our body, our self talk, our self compassion. It blew my mind that the key to my recovery was actually in self compassion. It wasn't a supplement or a medication, it was literally how I was speaking to myself. And when I started to learn this, I got better within a matter of days and weeks. I returned to a full time job. I ended up meeting my partner shortly after my recovery. We got married. We have a home now. And I am beyond moved to share this education and the tools that I've learned with others in the hopes that it will help them get out of their chronic conditions. And so that's my story today. That's it. Hopefully, I'm under time, but yeah, feel free to open it up for any questions.
Thank you so much, Dia. This was honestly so impactful, and thank you for sharing so much of your own personal story. I mean, it can be really difficult to talk about experiences like this. Just in my personal life, I actually have a very close friend who just went through a similar experience after a concussion, having a really long period dealing with symptoms. And I think I will be sending this to her, some of this to her as well. So thank you. Daria, did you have your hand raised?
Yeah, I was just wondering. I mean, obviously, we work a lot, and something that I know when we'd met, we ch chatted a lot about was this idea of like also gender health equity in this field, and kind of how being almost like silenced or unheard in this field is almost contributing to that. So I was wondering if you could expand a little bit more about kind of maybe some of the tools that you'd recommend for people to kind of like advocate for themselves in this field and make sure that their ideas are really heard.
Yeah, that's a really great question, Daria. I mean, first and foremost, you can feel a little bit crazy when you don't have someone validating what you suspect might be true. You can feel like you're going nuts. And so the first thing is to get your thoughts down. I started journaling and I would revisit my journals and see a pattern in my own thoughts and develop some intuition with myself. Trust in ourselves is so important because we know in our bodies what's happening better than anybody else. The second is to have an ally in your family or your friend group or your community who you can confide in and talk with. For me, that was my mom. And as I started to share this with her, she said, I think you might be onto something. And we started digging into the resources together and we found an app that educates people around this called Curable. You can check it out. I'm not associated with them, but that started sort of the journey. So it's your intuition, it is sharing with someone you can trust, and it is exploring the tools that are out there because they are available.
Amazing. Thank you. Okay, let me see. Okay. Well, thank you so much, Dia. If we don't have any other questions, I think we're gonna move. Oh, Elle, do you have a question?
Yeah, I do actually. Sorry, I couldn't find my raise hand function for the life of me. But I was wondering if you could maybe just share one piece of advice you might give to others who could be struggling with a condition similar to yours or any other sort of like chronic pain condition, because I know that, or as you expressed in your presentation, when you're living in the thick of it, it's really hard to maybe see that light. So if there's any advice you could share, that would be super appreciated.
Absolutely. Yeah. So on the chronic pain side, and the reason I brought that up is because a lot of the lessons I learned apply to chronic conditions across the board. There's a fantastic social worker named Alan Gordon who wrote a book called The Way Out. It is incredible and it speaks directly to chronic pain, symptoms, and conditions. I highly recommend starting there. He also has a lot of free content on his Instagram page. Just head over there, start looking at some of his stuff, listen to his podcasts. On the persistent concussion symptom side, I personally went to a clinic called Toronto Brain Health in Toronto. But looking for a neuropsychologist or a neuromental health therapist who specializes in these symptoms, not just a general mental health therapist, and someone who can understand the mind-body connection. For me, that was looking for someone who had learned the work of a doctor named Dr. Howard Schubiner and Dr. Sarno. So those are just some names that I'm dropping here. If it is helpful to anybody, please share this out and hopefully we can get the word out there.
Great. Thank you so much. Okay. So our next presenters are going to be Stephanie Malloy and Erin Keogh.
Okay, hi everybody. I'm just going to get my screen started there.
Perfect. Everyone can hear me?
Yep, sounds good.
Perfect. So my name is Stephanie. I'm presenting today with Erin. We're representing our organization, Justice Centered Rehab, and we're going to be focused today. So a little bit more about myself. Erin and I graduated together from McGill with our Masters of Physical Therapy. We both helped to co-found Justice Centered Rehab. And we're both calling in from Montreal, Canada, and some of my professional interests include mental health, global health, trauma-informed care, working with Indigenous people, people with homelessness, refugees, like those kinds of populations.
And like Steph said, I also graduated with her in my physical therapy degree at McGill. I am a person of Indigenous descent and I have a chronic disability. So when we joined with Justice Center Rehab to create it in 2021, we had a lot of great topics to discuss and present. My current research topics are Indigenous health, experiential education, disabilities, women's health, and sleep impact. So we are a volunteer-run organization at Justice Centered Rehab. We were founded by physiotherapy professionals and students to really address the lack of social justice and equity that we found within allied health and health rehab. We mostly use our website, social media, and blogs and online discussions to really talk about different topics that we're interested in and sharing. And that's why when we found out about this conference, we wanted to apply because we really use storytelling and patient-led narratives in our Justice-Centered Rehab approach, because we think it's so important to hear about our patients' perspective and how they feel in healthcare and their safety that they feel while they're being treated. Some examples of this is that we've talked with physios and occupational therapists who have disabilities. We do a series of posts highlighting the LGBTQIA2S+ issues. We did a sharing of physiotherapist Eddie Cardoso's performance of Stop Killing Us, Black Women and Obstetric Violence. We have this linked at the end of our slideshow, so we can share this with you later. And we have an upcoming conference about storytelling through the global narrative, depending on the global South and the global North, how that changes.
So we're going to talk a little bit more about gender disparities, specifically within the physical therapy profession. So looking a bit more at professionals rather than patients. So to begin, is physiotherapy even gendered? It is. It's a really female-dominated profession in Canada and globally. But in Canada, for example, women make up 73% of the national workforce. And many actually attribute the development of modern day physiotherapy to women because they were recruited to help orthopedic surgeons in World War I, helping with the soldiers restore their function. But despite this, there's still a lot of issues with gender disparity within the field, and we do have kind of some dark history that features gendered violence, putting down of women, especially across like social classes. So one of the key developers of the formation of the physiotherapy profession really globally was the formation of the Society of Trained Masseuses in Britain. And this was directly in response to the British medical journal's The Massage Scandals, which was a series of articles talking about how massage is like really improper, and the association of massage with brothels, and that like dirty women, I'm using quotations, and like prostitutes were using this, and that it's like a very dirty and bad technique that people shouldn't be using. So the STM was created to distance themselves from these dishonorable women, and to make massage a safe, clean, honorable profession that was like trusted by the public and really by male doctors as well, so that they could get referrals. And another example of the history of physiotherapy is that this is a list of 7 names, and we have 3 men and 4 women. I'm assuming most people here won't recognize them, but if you ask any physiotherapy student after their first year or two and any practicing physiotherapist, I can guarantee you they recognize 2 of these names, at most 3 of them, definitely not all 7. And the only names that they will recognize are the men, and they definitely won't know any of these women's names. We weren't taught any of them. And again, at the end of the presentation, there's a slide explaining who all of these amazing founders of physiotherapy are.
So when it comes to leadership, you would assume that because physiotherapy is a female-dominant industry, we would have a lot of female roles in leadership. Unfortunately, that is not the case, and that's why we're bringing it up today, that even though physiotherapy on the outside looks like a very female-dominant profession, under the surface, it's not actually as female-dominant as we'd like it to be. So in the tenure track positions at universities, they are filled with 46% male and 54% female. So as you heard, if 75% roughly of physiotherapists are female, that means that the positions here are not really balanced. In Quebec, where we are currently working, there are more male physiotherapists in leadership roles than women across the board, whether it's in leadership in hospitals, owning clinics, all of these types of leadership roles. There's more men than women. And all of the foundations that we have, like our regulatory bodies, any physiotherapy congresses, are all actually having men as presidents currently. There have been some females in the past, but it's still very male oriented. Pay is also a huge thing. So even though we have sectors in the public system that are supposed to be equal, it doesn't always equal in the end of things. So male physiotherapists are more likely to work full time and in a private setting. Men tend to have higher salaries in many allied health professions, so nursing, occupational therapy, optometry, speech language pathology, across the board. All of those also seem to have tended to have higher salaries, regardless of comparison. So they compared women and men who work full time and women and men who work part time. And even though those settings didn't change, there was a difference. So then on average, women end up having lower annual salaries than the men. As well, in research, we know that researching the female body, or people who identify as women or have vaginas, are very important to research. But even though there is a huge proportion of research that was created between 2000 and 2020, there's still way disproportionate of women. And we're way underrepresented in publications, grant funding, leadership roles, conference keynotes, and panelist members compared to men. So there's a lot of disparity there. In a 4-year study, there was 7 million people used for exercise health research, and only 10% of those in those research facilities were women. So all the research that has been published in those 4 years was primarily for a male dominant body, which we know is not accurate for our research. So in conclusion, there's still a lot of disparities within allied healthcare and healthcare in general. Women play both a vital role as both the patient and practitioner, and it's very important to uplift the voices of both. We need to continue to uplift these voices and advocate for change. When me and Steph originally practiced this presentation, we had about 30 minutes worth of content. So we're sorry we spoke so fast and that we didn't have time to get through everything, but we're very thankful to be here. And if you have any questions, please let us know. These are our pages. We will actually put them in the chat as well, so you have them. And then these are all of our references, and we'll send all of this to you guys after the presentation. So thank you so much.
Thank you both. I saw Elle's comment in the chat saying that some of this is genuinely shocking, as much as I think a lot of us know that there are disparities, and whenever we see it written out, it's always, I think it hits extra clearly. I think like what you guys touched on at the beginning of specifically like this perspective of like looking at patient storytelling and like lived experience. That's really like such a shared common interest between both your organization and medical history. So I was wondering if you guys could speak just a little bit more on that really fast.
Yeah, so that's kind of how we a little bit started getting up on our organization, was really finding people who wanted to share their stories, because we personally, both of us, have had negative experiences within the healthcare system being the patient. So we wanted to bring that lens of patient to practitioner into life, and understanding that these lived experiences can really change how the practitioner actually practices their ways. And so we got to learn a lot about different things to also advocate for other professionals to see this and see the damage that we can have to people's health depending on how we interact with our patients.
Mhm. Our upcoming project that we're working on disability perspective, global disability perspectives through storytelling. We're presenting it at the World Physio Congress, and we're going to create a website to hopefully get submissions globally of different people's perspectives of what disability is and what that looks like in different cultures. So we're able to get that firsthand understanding of like the word disability doesn't just mean one thing or look like one thing, and from culture to culture, person to person, that there's these huge differences, and we need to highlight that and understand that better.
That is amazing, and good luck on your upcoming presentations. I'm sure it'll go great. We have one other question in the chat before we move to our next speaker. Daria asks, are these ideas being incorporated into PT education, or how can we change PT education to be more inclusive?
So in Canada specifically, there has been a bit of a movement more towards Indigenous healthcare, because that's been a lacking subject for a very long time. And the universities are slowly actually implementing that more into their practices. Students have to do more like research, more classes very oriented towards these things. Unfortunately, I find in Canada and probably elsewhere, we're still very at the beginning of trying to have this movement put into healthcare. And I'm hoping it'll get better as time goes on. In Canada as well, I made a note of this when Jess Harvey, the artist, earlier talked about the conditions that happened. As a pelvic floor therapist, we're actually now in Canada one of the people to help you diagnose those things. So if you're having pain, you can come to see a pelvic floor physiotherapist, and we're able to help you kind of bypass the lines to be able to go see the correct medical professionals to help you with these pains. And we can also help you with the pain as well. So it's helping us to a little bit provide more care for more people and helping to decrease the pain and wait times.
That's amazing. Well, thank you both again, and I encourage everyone to go and check out their organization, and please send the information that you had previously mentioned.
We will. Thank you so
Um,
much.
of course. Amazing. So our next speaker is going to be Kate Lindsay.
Hi everyone. Can everyone hear me?
Yep.
Okay, perfect. So I'll just go ahead and share my screen. Can everyone see the slides?
Looks great.
Okay, perfect. So, hi everyone. I'll start by just introducing myself. So, as you heard, my name is Kate. I'm a third-year PhD candidate at McGill University here in Montreal. My program is titled Experimental Medicine, and I study specifically cardiac imaging and cardiac MRI. My research focuses on ways we can use novel, non-invasive imaging tools to better understand underdiagnosed and understudied forms of heart disease. So in my talk today, I'll start by first discussing ways that sex and gender can impact our hearts, and then we'll discuss some ways we can tie in clinical research and community advocacy to make a change here. So as I start my presentation, I want all of us to visualize, what does heart disease look like to you? For many of us, we might visualize that classic image of a man clutching his chest in pain, as we've seen in many movies, TV shows, or media. Now, this is of course one example of what heart disease can look like, but not the only one. Heart disease affects everyone, all genders, all sexes, all ethnicities and races. And it's important to know that women are not spared by heart disease. 1 in 3 women in North America die from heart disease every year. 1 in 3. Heart disease, even in 2024, is on the rise, and it's the leading cause of death for women worldwide, even in countries like Canada and the US, where we're considered to have a wide range of diagnostic tools and medications at our disposal. And this isn't only a problem for women who are older. Premature heart disease is a growing concern. That means heart disease before the age of 55. Heart and stroke is the #1 cause of death for women in Canada. So why is this happening? Why are these outcomes worsening for women in Canada and not getting better? To answer this question, we have to look at heart disease through an intersectional lens, considering a multitude of factors. Things like a lack of awareness at the research and clinical level, as well as within our communities. Factors specific to female sex and physiology. Racial and ethnic disparities in terms of medical care and within our society. Psychosocial factors that impact the heart, and gender roles in how we seek care and receive care. Both sex and gender impact the heart. Sex impacts the heart through our genetics, so factors that are passed down from our parents, our hormones, and interactions of these pathways. Whereas gender impacts the heart through stress, lifestyle, the way we seek and access healthcare, and psychological traits. There's also what I will call female sex-specific physiology. The causes of heart disease can be different in those who are female or assigned female at birth and those who are assigned male at birth. Let's think of our heart together like a house. We have 2 rooms upstairs and 2 rooms downstairs with doors, which are our valves, an electrical system keeping our heart beating, and plumbing throughout the house, which is our coronary arteries. In males or those assigned male at birth, they usually see heart disease in those large coronary arteries. Think of those as the big water pipes that you can see on the outside of your house. But in women or those assigned female at birth, heart disease can look a little different. Women are more likely to show heart disease in the small microvessels or the microvasculature. So think of those as water pipes that are hidden within the walls of our house. This makes it harder for doctors to see and diagnose with typical imaging. We also face female sex-specific risk factors across our lifespan. At a young age, due to, for example, PCOS, hormonal contraceptive use, our periods, endometriosis, then as we age through adverse pregnancy outcomes, such as gestational diabetes and hypertension, losing babies to miscarriages, and through older age, early onset menopause, ovarian cancer, or breast cancer. These outcomes all raise the risk of heart disease, but this has only been discovered recently, and many doctors don't consider these factors when speaking with patients. We can also present with different symptoms of heart disease. For example, more stomach or heartburn feeling symptoms rather than that typical chest pain. This leads heart attack symptoms to not be recognized in over half of women. Women are more likely to present with a wider range of symptoms than men, and just different symptoms, so they're more likely to be turned away at the emergency room. These also are compounded by racial and ethnic disparities. Black women are twice as likely to die from heart disease, independent of their age or other factors, compared to white women. There's also psychosocial factors at play. Brain health and heart health are intricately linked. Things like stress, anxiety, and depression increase our risk of heart disease, and recent research has shown that this might be even more important for women's health. There's also what we can call stress amplifiers based on our gender roles. For example, managing duties at home, intimate partner violence, caregiving or taking care of children at home, and balancing our work and home life. This shows us that a one-size-fits-all approach is not sorry about that. Let me go back, is not adequate to to treat heart disease. So we see this through factors not included in traditional screening, risk factors being underdiagnosed, our own awareness of these problems has declined, and at the national scale, female researchers are less likely to be awarded national CIHR research grants. So how can we help? On an individual level, we can each try to take care of our hearts by being active, managing our stress, and eating healthy. But we can't do it alone. A change of this nature requires awareness, advocacy, funding, scientific evidence, and changes at the level of medical policy. So as I end off my presentation, that's where I'd like to introduce you to Dr. Judy Liu, my supervisor, mentor, and a national women's heart health expert. She draws from personal experience as a first-generation Canadian, an immigrant, and someone whose family has struggled to receive care in Canada's healthcare system. Because of her experiences, we've created the Power Hub. This is a national network known as Pathways to Cardiovascular Care for women of ethnic, racialized, and remote communities. We're a multidisciplinary network of volunteers, researchers, nurses, people with lived experience, and community members committed to cardiovascular equity. We're a student-led organization with 4 of us students leading and organizing activities, including community events, seminars, leading research studies for our master's and PhD programs, and just raising awareness and raising our voices for this cause. We're currently based in Montreal and have partnered with a few different organizations in Montreal, but we'd like to take our network worldwide and countrywide. So if any of this resonated with you, please reach out. Overall, I think my key messages are that heart disease impacts everyone. There's so many factors that impact our heart: sex, gender, race, ethnicity, and we need to all work together to drive change. We can't do it alone. I'll just finish off with this quote. Our work should equip the next generation of women to outdo us in every field. This is the legacy we'll leave behind. Thank you, and please feel free to reach out to me directly if you're interested in this research, or reach out to us at the Power Hub. I've put up our links here. We'd love to collaborate, and we're always looking for more ways that we can advance heart health equity. So thank you.
Thank you so much, Kate. This was so interesting. Just in the interest of time, we have one quick question. Daria asks, what work is being done to incorporate some of these ideas actually into the physicians and the healthcare practitioners education? And have you guys done any push towards specific policy?
That's an awesome question. Really topical. So right now we are trying to push for some more education of healthcare professionals. Through our network, we're creating some heart health seminars. So we'll be having them in February on Wear Red Week, which is a Canadian-wide initiative for women's heart health. I'll be leading a seminar for students titled "What Every Student Should Know About Women's Heart Health" to have that change on the student basis. And then in terms of policy, we're currently brainstorming some ideas to create a standardized questionnaire about female sex-specific risk factors that practitioners can use when they screen women for heart disease, because right now that's not always taking place, and it's pretty important. So we're trying to bring that up on the Canadian policy level.
That all sounds so amazing, and I'm sure there's lots of people in the Zoom that are extremely interested and hopefully are there to support y'all's mission as well. Thank you so much again.
Thank you.
Okay, so we're going to move on to our last speaker for today, and that is Kartika Kumar.
I'm just gonna go ahead and share my screen first.
Yep.
Let me know if you can see it.
Looks
Okay.
great.
Got it. So hi everyone. Good morning, good afternoon from wherever you are. I'm Kartika. I am a clinician who studied in India and went to the UK to do my master's in public health. And right now, today, I'm going to be presenting my master's thesis, which is integrating gender in health interventions for adapting to extreme heat with a lens on LMICs. So we all know this, global temperatures have risen, and this has obviously led primarily due to climate change, and that has segued into a lot of extreme heat events across the world in different continents, especially in LMICs. So extreme heat events, although we know it causes like simple symptoms such as dehydration, tiredness, heat cramps, heat strokes, especially in men, it's known to cause anxiety and depression. But there are different impacts for women, and it is key that we acknowledge these impacts. Continued exposure to extreme heat alters sexual and reproductive health for women, causing altered hormonal balance, disruptions in menstrual cycle. Women are known to have increased obstetric complications from the point of getting pregnant up to the point of delivery. And not only does it affect the women who's getting pregnant, but it also affects the kids that they're looking to give birth to, causing fetal distress and preterm birth. So women in LMICs historically have known to have a higher risk of poorer health outcomes, but especially in the context of extreme heat, there are three key factors that we have to consider. The first one is the fact that women are 3 times more prone to have excess deaths. And this was kind of verified using the data set from the Ahmedabad heat waves in 2010, which is in India. And more than 200,000 women are expected to die in the coming hot years in India, Nigeria, and United States alone by 2050, which is not too far. Not only that, continued exposure also causes a 15% increase in preterm birth and stillbirth in the women who are exposed. These are obviously compounded by a multitude of social-cultural factors. Obviously, the first one is the fact that women are different from men, but the other social-cultural factors, especially in LMICs, are environmental factors, socioeconomic factors, and all of them put together showcase to us the fact that gender does influence a woman's experience to extreme heat. So that led to me kind of wondering, okay, so women do have so many problems, so what are we doing? And if these interventions for women do exist, how do they consider gender in them? So it might be a research gap or something that we can learn from. So that led to my research question on how do LMICs integrate gender consideration while implementing health interventions to adapt to extreme heat. With these objectives to find these interventions first and try to analyze these interventions using the WHO scale and to see if there's gaps and any best practices that we can use to guide future interventions and policies. Again, we use the JBI guidelines. For those who know, this is extremely academia focused, but yeah, we tried to look at the adult populations in LMICs with the concept being at 2 levels, which is the EH adaptations for health and also the integration of gender as a second level. So how did we do the assessment? So the WHO has a framework where it tells interventions to be designed in a way that it becomes gender transformative. And often it is recommended that that the people who are making these interventions follow those guidelines. So we use those frameworks to form a 6-point scale amongst 5 different categories, where 0 would be the lowest score that we could give to a study that we would find, and 5 being the highest score that we could give to a study that we could find. And then we average these scores and then put these studies on the gender continuum as suggested by the WHO, where the lowest score would be gender unequal and the higher score would be gender transformative. We ended up doing a scoping review with the inclusion criteria of looking at only peer-reviewed literature with human studies that looked at community-level interventions and should report some form of health outcomes, and ideally in English, and should be published from 2013 to 2024. These dates were specifically chosen primarily because that was when the gender framework was published by the UNFCCC and the WHO. So we took the starting point to see, okay, this is where we've been telling you people, so let's see what we've been doing in the next few years. So what are the results? Okay, for everyone, I want you to keep a number in mind. So we start with 524 studies. Keep a number in mind on how many studies we actually found. Feel free to throw it in the chat box if you think you know the number. So we found 524 studies in different databases. We removed references. We screened for title and abstract with 433 studies, out of which, using our inclusion and exclusion criteria, we ended up doing a full text retrieval. And we finally came up with 5 studies across LMICs that we're looking at the health interventions for adapting to extreme heat. So where are they from? Nicaragua, El Salvador, Burkina Faso, Pakistan, and India. So different continents, different places, different interventions overall. So if you look at the overall picture, we try to classify them using behavioral interventions and technical interventions. Behavioral interventions kind of mostly revolved around creating awareness programs on teaching people how to drink water, rest more, access shade if you're extremely exposed to extreme heat or if you're extremely tired. Technical interventions primarily revolved around cool roofing. And these basically meant like you structurally alter your roofs to either paint them with a white paint or a non-heat productive material. So it's able to dissipate the heat in these housings more. Now, if you look at the extent to which gender was incorporated, we assessed these studies and TLDR if we didn't do that well. With only the study from India, which is Valangri et al. Scoring a very high score, being gender transformative initially, while the others ended up being bucketed in either gender blind or gender sensitive. However, we also ended up taking a narrative analysis of the full text itself that ended up bumping down most of these scores furthermore with a final list of the Valangri et al. Trying to be a bit more gender specific. 3 of these studies ended up being gender blind, while the final one being gender sensitive. So what are the critical gaps considering we did a scoping review? So it kind of highlighted the fact that even though there were 524 studies that we were able to bring out from the databases, there were only 5 that looked into health adaptations, which kind of is very representative of how climate change and how climate is being talked about in the research field right now, that we often don't look at the health impacts. To be really honest, the recent COP29 is happening right now. It's been 5 days. There's not a single document that talks about health yet. And for the first time last year, they declared the Health Day, and we've had COP29. So there's been multiple COPs that's been happening since 2013. The other thing is that often adaptations for climate change have a very significant emphasis on agriculture, livelihood, and economic security, which is not wrong, but we do have social determinants of health, and we should leverage these insights to push and find out what the health impacts are in these interventions. The second critical gap was the fact that if you look at a broader picture, 4 out of the 5 studies did not even consider the gendered impacts of extreme heat, which again is representative of most research fields, and especially the climate research field, where gender is often used as an additional explanatory variable. We do not look at gender data collection. We often look at gender disaggregation. At the best, most studies, at least in LMICs, just look at sex stratification and nothing more. However, it is also key to note that probably the underrepresentation of women in most of these studies were probably due to the gender biases that were entrenched in the societies. For example, the Nicaragua study itself was conducted in a sugarcane factory, but in Nicaragua, often women are not officially employed by the labor sector, and they do not fall into these documentations, and these studies itself couldn't reach out to these women. So even though there's mention of these women in these studies, they're still left out. Of the reviewed studies, we had multiple limitations. There's varied sample size, varied representation. You can't compare any of these to each other because they're just so diverse. There was heavy reliance on self-reported data to measure things like well-being. There was obviously, because it's an LMIC, there's interventions are incredibly hard to be sustainable. More than that, you cannot scale up these interventions at all. Of the scoping review itself, we are well aware that we did remove a lot, we did choose to exclude gray literature, and also the non-inclusion of non-English studies. So we did miss out on a lot, reducing our scope. Not only that, it made it incredibly difficult for us to do direct comparisons because there were diverse study design, and also the lack of gendered reporting made us to re-look at what our perspectives on gender transformative or gender specific was, which required multiple reviewers to look at the studies as well. So what are the recommendations? I think it's high time that we do explore the intersection of health in these existing adaptations. We have a rough estimate of 400 plus adaptations across the world, with around 90 plus in LMICs. And all of them, at the end, if you look at the health intersection, there's barely 2 or 3 that is kind of unfair for the health sector. We should look into integrating the social cultural determinants of health into these interventions and looking at that angle. The second is we do have a gender responsiveness framework. It's been a decade. Why aren't we using it? We need to get policymakers and intervention designers to use these frameworks to guide intervention design. The third and fourth one kind of go hand in hand. Local communities know better, so engage these local communities. And also because LMICs have incredibly hard times in sustaining interventions, it just makes sense to use local resources and knowledge in LMICs. So these are my take-home messages, and thank you.
Thank you so much. We have one quick question, and then